SparxCast Unleashed. Real stories, real health innovators. Today, our host Reese Gomez speaks with Dr. Mitch Morris.
Really excited to do the podcast today. Extra excited about the guest that we have today, who started out his career a cancer surgeon, doing some amazing work, saving lives, and then wanted to start to get into the IT side and became the CIO at MD Anderson. Really enjoyed that and moved over to become a management consultant, eventually becoming the head of all of Deloitte's healthcare consulting and life sciences. Really excited to have Dr. Mitch Morris with us today. Mitch, thanks for taking time to meet with us today for our podcast. Really nice to have you.
Thanks, Reese. Great to be here. I always enjoy our conversations, and I'm sure I'll enjoy this one today.
One of the things that's been really interesting, Mitch, in the last 2-3 months, especially as AI has become even more prolific, I just kind of wanted to get your sense on where you see AI and innovation tying together and where you see the promise and where you see the risks.
Running an accelerator program like I do now, we see lots of companies coming forward in health IT, pretty much all of them AI in some way. They're usually referring to large language models and generative AI because machine learning, natural language processing, et cetera, have been around for quite a while and are built into lots of things. And I think what's potentially transformative, and I say potentially for a reason, is the use of large language models to have things like conversational agents, much more extensive insights into unstructured data, and the automation of workflow way beyond robotic process automation. And those things hold great promise, I think, in healthcare. It's hard to tell which are the companies that are going to be most successful, and certainly some of the ones with very deep pockets who are investing in Epic is investing heavily in this, as is Oracle. Oracle/Cerner now says that their EHR is going to be completely AI driven. We'll see. Those kinds of things are always more complex than anyone thinks. So we'll see how it works in reality. And then there are companies like Apple and Microsoft, et cetera, also working in healthcare area. And against these deep pockets, you have got hundreds, if not a few thousand, early stage companies that are focused on using AI in healthcare. I see a lot of companies where the founders are super smart. They've got a great idea. The questions will be, do you have enough capital to make this happen? What are your competitive advantage and differentiation from the other things in the market that might sound a lot like that? How are you going to navigate the complexities of payers and providers and the regulatory and compliance area, who pays for what? And folks haven't always thought that all through. But as time goes on, I think we'll see it more AI-driven apps, particularly things that are large language model related, getting more and more into the day-to-day of healthcare. Some of the unanswered questions are, how do we prevent bias from being introduced? Are some of these things medical devices? Should they be regulated by the FDA? And there are guidelines from the FDA on that on their website. And there's a whole emerging group of folks who are opining on the ethical and practical aspects of the use of AI in healthcare. So time will tell, and I'm sure you're seeing a lot of companies that are doing the same thing.
Well, we are, and I think the interesting part is one of the big questions we get a lot is what's the return on investment on all of this, and how is it fundamentally get to where we want to be, which is to make healthcare better, right? Make it better for the patients, help doctors be more productive and be able to get home for dinner at the same time. And so I was just kind of curious if you got a sense in terms of the applications of AI. I feel like there could be a bit of a dark side to it too. I remember back when EHRs were first coming out and this notion of copying a clinical note forward was pretty cool. It's going to save a lot of time. But the reality is you ended up spending a lot of time just editing what wasn't relevant anymore. And you wonder whether or not it actually ended up saving you any time. And I feel like with AI, is it really ready for prime time? Is it accurate enough? Is it actually going to potentially cause more patient safety issues than it's going to solve, at least in the near term? So I was just kind of curious if you're seeing any applications where you feel it's lower risk, higher return, and how you might think about that from your perspective.
Well, I'll tell you from speaking with CFOs at health systems around the country, they are inundated with different requests. And one of the the medical staff or the faculty went to RSNA or ASCO or the College of Surgeons, and they come back, oh, we've got to have, or it's Consumer Electronics Show, we've got to have this thing. It's essential for patient care. And then the CIO takes a look at it and goes, I'm not really sure how this is going to fit in with everything here. And it also gets to some of the issues around safety and efficacy of these add-on applications, if you will. I also look at the use of AI to help lower costs or increase revenue. So how do I more effectively use it on the business side of facilitating operations, facilitating and better understanding the use of my capital equipment or resources, understanding my contracts with payers, understanding my contracts with providers. How do I make sure I'm getting paid the right amount and things like that? There's a lot of unstructured data in our world, even with EHRs and claim systems. And I think that on the business end, some of the things we're doing in AI can really help take some of the friction out of the health system and help it operate more effectively. Now, what you're bringing up a little bit is like, well, when do we let AI make judgments for us around healthcare decision making? And I think we're a ways away from that. And ultimately, human beings today, anyway, need to apply their own judgment based on their experience and skills. And AI can help facilitate, but not necessarily make the judgments. There are a number of areas where I'm seeing AI companies do things that take an administrative burden off of, for example, nurses who are trying to do care management and disease management. There's only so many nurses and so many hours in the day. And there's a lot of what, when I was in medical training, we used to call scut work that is not value added, but has to be done, that AI could do some of that work so they could spend their time doing what they signed up to do in nursing to begin with, which is helping people lead healthier lives and be better. And I think we're starting to see a little more focus on that rather than I'm going to replace you. I don't think that is the focus. It's how do we augment and enable doctors, nurses, pharmacists, clinical staff, non-clinical staff to do things faster, better, cheaper, and focus on the things that do require skill, judgment, experience that they bring to the table. That maybe AI will be ready for that one day, but probably isn't ready for it today, at least in the iterations I've been seeing.
That makes a lot of sense. I think the thing that this is a broader question, so I'm going to switch gears a little bit on you, but I'd like to get your opinion. It just seems like healthcare just continues to struggle. It's this horrible situation with the United CEO being shot, and people actually cheering that on. And when you start to think about hospitals and insurance companies and the pharmaceutical industry, it just doesn't seem like, I don't know, in the public perception anyway, that things are getting better. And I was just kind of curious your thoughts around that, kind of what you see as where technology might make the biggest impact on making that happen. And how do we get there? Because we spend a lot of money in this country. I don't know exactly the numbers, but I know we spend as much as anybody on a per capita basis, and we just don't have the outcomes.
3 times as much as any other country. Well, we don't have enough time to discuss all of the complexities. And I think one of the challenges in the reaction to the assassination of Brian Thompson is that people don't really understand what's wrong with the healthcare system. And I don't usually watch Bill Maher, but I happen to be on in the background. I'm listening to him. And he was talking about the killing. And he said, yeah, I understand why people would want to kill insurance executives, because insurance companies do. And he listed all the bad things people think insurance companies do. And then he listed a bunch of things that doctors and hospitals do, and surprise billing, and all kinds of other along those lines. Pharmaceutical companies, PBMs. Basically, he said jokingly, in the usual Bill Maher way, we should be assassinating all of them because they all have a role. If you're going to think it's not just the insurance companies. And Andrew Woody had the CEO of United Health Group, had an interesting piece in the New York Times where he now famously said, we didn't invent the system that's here today. This grew up over decades. And to what you're saying is the system fundamentally is broken because the incentives are wrong. And the challenge is how do you redo the incentives in a way that doesn't cause a lot of suffering and pain during the transition. Technology is one way of helping. I know several companies that are working on healthcare denials and denials management. How do we do prior authorization and use AI to help us do prior auth so it doesn't get denied? And if we were really good at doing prior auth, we might get a gold card from the insurance company, which is basically, I'm going to accept all of your prior auths without denying them because you have such a good record of doing it correctly that I trust you.
Right.
And then things are much less likely to get denied. And it's very hard to do that using human power, but maybe it's easier using an AI agent that would go out and create the right things that both ends of the spectrum, payers and providers, both of whom like to make profit, because, even Marcus Welby was for profit. He did have to take his spouse on vacation to Europe once a year or something. For-profit system is here. How do you do it fairly and equitably that promotes health and not catch consumers, patients, members in the middle, which is what happens today and why people are so unhappy about it. The other thing I'd say about, yes, our health outcomes are, by some measures like life expectancy, worse, but a lot of our life expectancy has to do with gun violence, alcohol, drugs, suicide, and the fact that a lot of people are uninsured in this country. So that leads to an earlier death and lowers our life expectancy. But if you somehow live to be 65 years old and have Medicare Advantage, and there's a good chance you're going to live to be 95 years old because we have a wonderful system for fixing broken things. We do not have a good system for preventing you from getting sick in the first place. And that gets to the incentives. And great at sick care, we are not good at blending health and social care so that people live long, productive lives. And that's not going to be solved by technology. That's going to be solved by policy. It might be enabled to some degree by technology.
It's interesting. I've heard an anecdote. I don't know if it's true, or some stories about, 2,000 years ago, Chinese doctors, when the baby was born, the parents would pay them, regular on a monthly basis. And as soon as the baby got sick, they stopped paying them. To your point around the incentives, recently, Dad, he had his congestive heart failure and he had an issue. And, the emergency room was amazing, got him into the ICU. It was amazing how great care they took for this really emerging situation, really kept them alive. But the cost was just phenomenal. It was huge. And I think back, I'm like, well, he's 91. And to your point, since 65, it's probably been $1 million or more in care that's been done. If the system had been set up from an earlier age to catch some of the things, like, for example, one of the reasons he has as the issue that he has is that he had the strep throat when he was younger. He was in a rural community and just turned into rheumatic fever. And so just access to care, that was a long time ago. We're not going to fix some of those kinds of things, but there's some of these root cause issues, Mitch, that are really causing these downstream issues. And so it seems like it's a policy issue and it's an allocation of capital issue. And then it's also technology that comes into the mix.
You're absolutely right. Costs are also high because we're living longer. So there's more bad stuff that can happen to you that we can take care of. The specialty drugs, the medical devices, the scanners, and all these things, they're very expensive. And we didn't used to have all that. And that's part of why healthcare is also expensive these days, is we have medical technology that's advanced in amazing ways, but that stuff costs a lot of money. So just as in the election, people have a fairly simple view, eggs cost too much, therefore we must change. Healthcare is broken, therefore it must change. But very few people understand the complexities. Why does it cost so much? And how did this system get to where it is today? And I don't expect most people to be interested in figuring all that stuff out. But we as healthcare leaders should have a good appreciation of the overall healthcare ecosystem. And I've been fortunate in that I've worked for and with payers and providers and life sciences companies. And the great majority of people I meet who are leading these companies mean well, they're out to do good, but the way the system is set up creates a lot of friction between them. And then we as consumers of it see the end result, which is high prices, access problems, getting caught in the middle of like the prior authorization game, and it makes it difficult. And as no longer practicing physician, I kind of work the system, and I have trouble doing it. People who don't understand how the system works don't know how to work it when they get a denial, or it takes too long to get in to see the doctor, or they're a long time in the emergency room. Those are all problems the great majority of people in this country face every day.
Well, and to the point you made earlier about the scut work and allowing clinicians to work at top of license, it's a minor miracle that people come out of the hospitals at all. There's so many things that can go wrong. Taking them off meds that make their blood thin because they can't use that anymore for a while. But then when they get out of the hospital, they need to start it up again and they forget to tell them. Or there's all the kinds of things that AI could really help with in terms of doing those things. It could also make a mistake just like a human could. How do you make those balanced decisions there?
It's true. And, back to AI is how does AI help people, whether you call them patients, members, consumers, but just people, how does it help them take control of their own health so they can stay healthier? Part of it you have to want to, and I'll come back to that in a minute. And the other is I have to have the tools to do it. And that's some of the most exciting developments I'm seeing in digital health is tools to help people stay healthier at home. And whether it's a continuous glucose monitor that gives you feedback on what you're eating and what time of day you're having a problem and what did you eat chocolate cake. I've been diabetic for over 20 years and I use one. And it's an amazing technology tool that hooks up to my iPhone and gives me great feedback on what I'm eating. And I had a pizza last night and woke up, my fasting was 138 this morning. And I go, I probably shouldn't have had that. So it gives me feedback to take much better care of myself. But people also have to be willing to do it. Today I was listening to the confirmation hearing of Robert F. Kennedy. And one of the things he said, we have to have people eat healthier food without ultra-processed food and all that kind of stuff. One of the senators said, well, you're going to force people to eat that? Paraphrasing, he said, oh, no. My boss eats a cheeseburger and a Diet Coke. We're not going to tell people what to eat, but we should let them know. And I'm thinking to myself, when I was a little kid, quite a long time ago, and my mom would tell me I had to eat 2 servings of vegetables a day and I shouldn't eat a lot of candy. And I've been basically told all along for 60 years what I should eat and what I shouldn't eat. And I often ignored that advice because some of the other stuff, there's some big cultural things about chronic illness in this country of diabetes, heart disease, substance abuse, alcoholism, things that by and large are preventable if you do certain activities and more likely to happen if you do other activities. These are not secrets. People know this and they choose to do it anyway. So this is, to me, one of the hardest things. How would technology help assist people to take better care of themselves in their own lives without going to a doctor necessarily until they're broken? And how we have some of the cultural shifts that are necessary to help people appreciate not eating ultra-processed foods. I mean, we've been very good, for example, in smoking. I recall getting on an airplane and there was a little ashtray in your armrest in every seat. You couldn't smoke before the plane took off, but as soon as the plane took off, half the people on the plane started smoking immediately. And now there's some furtive people hanging outside the airport in some designated smoking area. And they're like less than 0.1% of the total people at the airport. So culturally, we have made a change successfully around smoking. How to make the same changes and other things, I don't know, but that's the direction we have to go to lead healthier lives. And again, getting back to AI, it can sure facilitate it. And I'm working with several super creative companies that, for example, one early stage company has a conversational AI agent that after you leave the hospital, checks in on you every day and asks you questions. So if you were in for heart failure, your legs were swollen yesterday. How are they today? Are they better or worse? Did you have a chance to weigh yourself? How are you feeling? Any shortness of breath? Were you able to eat? Any questions about taking your medicines? Now, in an ideal world, someone would do that with you. It's very complicated after you leave the hospital, and you're often anxious and depressed, and maybe lonely. Having a conversational entity ask you about that stuff and follow up from day to day can really give you some personal tools to improve your adherence to your medication and diet, and then also detect when things aren't going well, because a lot of people wait till they're really sick and then show up at the emergency room rather than when they're a little bit sick and maybe your nurse could call you. Maybe you need to come into the office to get checked before you get so sick that you're in the emergency room. And also identify economic fact. Why aren't you taking medication, Reese? Well, I went to the pharmacy and it's really expensive. I don't have that. Oh, well, there might be another medication that's much less expensive we could change to. That kind of stuff doesn't happen in our system very well. Once you leave the hospital, it's like make an appointment to see your doctor in a month. And what happens in that month?
That's when you get sick or better. Interesting point about cigarettes and candy bars. What made me think about, Mitch, was, when cause and effect are separated in time, it's very hard for us to know that what we're doing right now is going to impact us in 10 or 20 years, or we kind of don't care at some level. And what I kind of hear you say with some of the AI and like the where you're able to monitor, performances, like you said, 138 was the blood glucose. Didn't eat the pizza last night. If you didn't have that technology, the cause and the effect, you sort of feel the pain. It can kind of help you feel the pain, and maybe that'll really help to change behavior because, to your point about the stigma of smoking, you see somebody smoking lighting up inside, everybody looks at them. But, you see somebody eating a Snickers bar or, a big thing of cake, keep doing that. Now, maybe, absolutely. And there might be, 30, 50 pounds overweight. You're like, you're going to be diabetes in a while. But, nobody thinks about that. But if that person said, oh my gosh, my watch just told me when I ate that piece of cake that something bad happened in my body. Maybe I didn't feel the pain, but something wasn't good. Maybe those are some of the things that could help to make a difference.
Feedback is great. Nagging is bad. The reality is everybody knows if you're overweight, I know I shouldn't be overweight. If you don't exercise, I know I should exercise. People know all these things, but getting, contemporaneous feedback on some of your behaviors, activities, and what the impact is could really help. And the other thing I think has great potential about AI is we've called it mass customization, personalization, is everybody learns differently and reacts to incentives differently. It's not one size fits all. And some of these emerging applications in AI that are consumer oriented take into account your educational background, your economic background, your gender, your age, your ethnicity, your culture, and just even within those, there's lots of variation. Learn who you are and say, I'd like to change Reese's behavior around certain things. What's the best way to do that? Because a lot of programs today, I'm not talking about computer programs, programmatically around health and disease management, it's kind of one size fits all. This is what we say, this is what we do. Some people use it, some people don't. And the uptake can really be improved by understanding how to tailor it to you as an individual through personalization. And that would be very hard to do if you're a person. When I was a practicing physician, people would come in and I would try to get a sense of how to best explain, as talking about cancer, it's a very difficult conversations. What did I think the best way to explain it to this person is based on how much I know about them, which was usually not all that much, but I did the best I could. And if you are working with an AI that gets to know you better, how do you respond best to information and learn and change? I think that would be a very powerful application of that.
No, it makes a lot of sense.
Companies that are working on like personalization, but we have a way to go with that.
But you could bring up a really good point. That's really where the next level is, because you can't, as a physician, for example, you know your patients as well as you can, but with the volumes you're seeing, there's only so much you can do, and still, things that you need to do the surgeries, prepare for the surgeries, education as you need to. I'm going to switch gears a little bit, Mitch, because you're in I think a really rare situation where you were both a buyer at a senior level at MD Anderson as a CIO, and then, selling large scale change efforts, that kind of thing, when you were at Deloitte and other consulting firms, and at Optum, leading their provider practice. Over the last, couple of years, what we've seen is two things were kind of on the minds of most of the C-suite, CEO especially: staffing and getting the right people in place, and costs, because inflation has been out of control for the most part and starting to get a little bit better. Are you seeing anything in addition to those areas that have risen to the top over the last year or so, or do you think those are still the main areas of focus?
Well, those are certain, staffing and having a high performing team is certainly clearly continues to be a big issue. And then also managing costs and managing revenue, especially around denials, are large areas of focus. My thoughts are a little bit colored by who I speak to, and I tend to speak to CEOs and COOs and CFOs. If you speak to physicians, their focus is, I am overwhelmed with gut work in terms of paperwork, and electronic medical record has helped in some ways, but is burdensome. My son is an associate professor at UT Southwestern and a surgeon at Scottish Rite Hospital for Children. And when I'm staying over his house on Saturday morning and I go for a bike ride or let's some football, he's got this stack of papers that he printed out. He's on his laptop filling out things that had to be documented during the week. And he's a pretty smart guy. It shouldn't and efficient, so it shouldn't be like that. A lot of my physician colleagues, young and older, are very frustrated and burned out by a lot of things. So figuring out how to my example with the nurses is true of physicians, is how do they optimize the amount of time they spend doing the work that they want to do and why they went to medical school in the first place. So clinical efficiency and effectiveness, getting back to a category, is an important one in dealing with physician and nurse burnout, is related to that, kind of go hand in hand. The whole move to home care, more ambulatory and now more home care, I think health systems are trying to figure out, how do I participate in it? Do I own it? Do I partner for it? And how do I have continuity of care? So when someone is sick and comes to the hospital or comes to my clinic, how am I going to take care of them in another setting? And then the health plans are thinking of the same thing, because we want to keep our people out of the hospital because it's good for business and it's the right thing to do. So how do we give people tools to stay at home and get cared for at home? And you see a number of health plans investing in and partnering with things that happen to you in the home to keep you healthier, stay at a hospital. So that's another, health plan side, another aspect. Ultimately, the goal is to decrease medical loss ratios and overhead. But the way to do that is to keep people healthier and out of the hospital, which is a good thing. No one wants to be sick enough to go to the hospital. It's a horrible experience for the patient and the family, not because of bad care, but because you're so sick that you're worried you might lose your life or have a change in your life like you were with your father.
And you're interacting with these folks, and I know you have a broad network of contacts, but kind of putting yourself in your shoes when you were CIO and making major purchase decisions, knowing some of the folks that a lot of our audience are people that are selling software or they're selling some sort of service. Do you see any kind of common themes in terms of, if you were sort of thinking back, Mitch, when someone came in and there was looking to evaluate, what set companies apart? There's something I need to pay attention to, and what annoyed you about the process as well?
Yeah, well, I want to tell you, back then, I was interested in stuff. This was the beginning of the internet and the beginning of electronic health record. So I was interested in stuff that I thought would impact patient care in a positive way. And I really didn't think about the finances of this as much as I do today. My advice to people who have, whether early stage or growth phase company, pretty much any company, is ultimately to know who the buyer is, who's going to sign the check. And very often it's the CFO or the COO that is going to make a financial decision. And I find that today there has got to be a value proposition that doesn't theoretically lower cost, it lowers cost or increases revenue. And anything else outside of that might be a nice to have, but is not an imperative to have. And yesterday I was speaking with Amir Rubin, who I've known for many years through his different iterations, who now has a venture capital company, Healthier Capital. And he was relating to me, one of the companies goes in and says to the CFO, this is how much we're going to save you, not next year, not next quarter, next month. And that is a really powerful tool. So It's concrete. It's not theoretical. We're going to lower cost, increase revenue, and hopefully along the way solve some of the other problems. One of the companies I work closely with at Caduceus Capital is Caduceus Talent, and the parent of that is called ProRank. And what they use is some AI-oriented search engine algorithms to identify candidates in healthcare for hospital systems at a much lower cost, much more rapidly than the traditional staffing agencies and search firms, ranging from junior level positions to senior positions. So you can go into a health system with a couple of qualifications and say, what's your spend on nurse staffing? The stuff that's per diems and stuff like that. That's a huge expense. And what you want to have is the right amount of staff at the right time with the right skills. And how can we get you there faster, better, cheaper? It's a powerful value proposition. So somehow you've got to relate back to whatever the core problem is that your company tries to solve. How do I do it faster, better, cheaper? So it saves you cost or increases revenue in some way. Those are really compelling propositions. I've seen companies that have these really great technology-enabled products that improve clinical outcomes. But ultimately, the person who's going to sign the check is going to go, that decreases admissions. Well, admissions are good for us because that's how we make our money. Now, I don't like that view, and they don't like that view, but that's their thinking.
Yeah, no money, no mission.
So you've got to be able to articulate a value proposition that the person who's going to write the check is going to say, this is going to make a difference for us. And ultimately, it has to be not a financial drain because I'm paying you money. It's got to save me money or make me money.
Yeah, no, that makes a lot of sense. Over the last few years, I know you've been doing work for private equity firms and venture firms, and it sounds like you're getting more involved in a venture you've mentioned a couple of times with Caduceus. Give us a little bit of background on what you're going to be doing there and what the mission is of the company there?
Sure, it's super exciting. I mean, I spent the last couple of years working with both early stage and growth phase companies and sometimes on M&A with private equity. Some of the ones I've worked on with you, which has been fantastic at SparxCast. And I really enjoy the strategy of how to help a company mature and grow. And I very much enjoy coaching and mentoring. And I wanted to scale that some. Caduceus Capital Partners is run by two fellows as managing partners that I've known for quite a while, Dave Vreeland and Scott Colasar. And their first fund was very successful. They're finishing a raise for their second fund, which may be oversubscribed, which is a good thing. They typically are writing for late seed, Series A type of investments. And the question is, well, for these young founders, some of them are old, but most of them are young, how do we help them have a greater chance of success? The healthcare ecosystem is so complicated, and a lot of them may have be super smart, have a really great product, maybe already a minimal viable product that they're ready to bring to market. Who's going to pay for it? Why are they going to pay for it? Is this a medical device? Do I have to get FDA approval? Do I need a CPT code? Should I go to the payers? Maybe they should pay me. How do I build a sales force, something that you're expert in? How do I bring on a technical team? Do I have contractors or employees? How do I make a pitch deck? How do I raise more money? Caduceus Launch is a hybrid accelerator. We're going to be taking 5 or 6 companies twice a year, so 2 cohorts of 5 or 6 over the next few years. It's a 12-week program with 1 week in Nashville where it's based, where Caduceus Capital is based. That's kind of like a fixed curriculum, and the rest of it is going to be a bespoke program for the needs of the founders and their team, adding on the content. And one of the neat things about Caduceus Capital is the investors in the fund are current and retired health system and health plan executives, consultants from Deloitte, people from Optum, from EY. So people who really understand healthcare. So each company gets assigned a mentor. And after the 12 weeks, we don't give you a firm and hearty handshake and send you on your way. We stick with you and continue to mentor. Hopefully, the next step would be a 7-figure check, whether from Caduceus Capital main fund or from other funds. And the other benefit is that this network of investors knows who you can sell to and can make introductions to health system leaders, to health plan leaders across the country. So I'm excited about getting started. We're going to be at 5 this year. We already got a number of applications. If you go to caduceus.vc, you'll see the link for Caduceus launch and where to apply, all the details on some of the terms and conditions of what a company would get from coming into the program. We have a number of applicants. I'd like to have even more, and I'm stoked about getting this off the ground, launched, if you will. And the goal ultimately is to help promising entrepreneurs get their company, warp speed where it's successful and ready to get greater investment dollars and work towards significant ongoing growth and profitability.
Well, you're the perfect guy to do that. The interesting thing is how much innovation there is out there in the marketplace, but it gets stymied by all the things that you said. Is you got some folks with great ideas. It's one thing to have a kind of an initial set of relationships or a great idea, but then how do you get out there and scale it? And it sounds like you're really solving that problem. What I'd like to do, Mitch, here is, as we wrap up a little bit, is maybe just find out a little bit more about you. You decided to become a physician and have what is a gauntlet of work. I don't have to tell you what you had to go through to deal with it. What was the what motivator? You had a lot of different options. You could have taken a bunch of different paths. What made you get into healthcare?
Well, I was very much influenced by my Uncle Dave, who was the first cardiologist in the state of Oklahoma.
Wow.
And he continued to practice on some level until he was 93 when he passed away, and also played golf. But in his 90s, he would go to the hospital, read a few EKGs, go to the club, play 3 holes of golf, have lunch, and take a nap.
I like your Uncle Dave already. That's like a perfect life right there.
If you're 93 and can do it, that's cool. But he influenced me, and I just loved science. And I, decided in high school I was going to go to medical school, and I really became interested in medical school, and then even more so in residency and in cancer problem. I was a gynecologic oncologist. And all my practice years at MD Anderson, where I did new drug discovery and clinical trials there, and I led national clinical trials, one of which changed cancer care for women with cervical cancer, the first major change in 40 years. It increased the survival rate by 40%.
Wow.
It was a lead article in the New England Journal. So during that time, I was always interested in technology. When I was a freshman at University of Michigan, I took Fortran as my foreign language requirement. They later closed that loophole. I had to take Spanish. Probably.
That's creative. I've never heard that before.
And I started getting very interested in quality, evidence-based practice, and how you apply technology. And that led me to be Associate VP of Informatics, which was kind of a new phrase in the early 90s, and then CIO for like 5 or 6 years. And then kind of got tired of academia and went into consulting, first on the technology side, then the strategy M&A side at Deloitte, and then ultimately led their life sciences and healthcare practice globally. So I've always kept in touch with the science and healthcare side, but got more interested in how technology enables it. So one of the things I was also at MD Anderson was professor of health services research. But how do you access data to really understand the outcomes of the care that you're providing so you can improve it? And I helped get the UT School of Biomedical Informatics, now called the McWilliams School, up and running, which now are the largest schools of it and highest quality of its kind. So those were very exciting years. My Deloitte time was very exciting. I loved being an optimist. I loved doing a startup company for a couple of years, which I did in Miami, if you recall. And I'm loving what I'm doing right now.
No, that's great. Well, thank you so much. It's been really, really helpful. Really, really fun to interact and kind of understand your perspective, and really interesting. And appreciate you taking the time to speak with me. And I know our audience will really appreciate the insights. Anything before we close here you wanted to end with here?
No, I love working with you, Reese. I mean, I think one of the big challenges that growth companies have, is figuring out how do we get to the next level, and it's how you put yourself forward, the wrapper you put around yourself, how you sell, how you describe your value proposition. I've learned things from you over years on how you approach that, and look forward to involving you in Caduceus launch and staying close to you on the sales part side.
Absolutely. Well, that's high praise coming from you and much appreciated. Well, you have a great rest of the day. Enjoy Carmel on the beach and have fun.
SparxCast Unleashed, Sales Sparks production, accelerating healthcare innovation.